Hello, I'm Nick Pyrsopoulos. I'm a gastroenterologist and transplant hepatologist at Rutgers, New Jersey Medical School, and I'm glad to be a part of the 6th annual Digestive Disease New Advances in Philadelphia. And this is a national meeting, and excellent topics were discussed today. I'm accompanied by
Stephen Brant. I'm the Chief of Gastroenterology at Robert Wood Johnson Medical School, the sister medical school to New Jersey Medical School. And my area of expertise is inflammatory bowel disease. And thank you, Nick, for inviting me to participate in your outstanding program here in Philadelphia.
Thank you, Steve. We are really honored having you, and as an expert in inflammatory bowel disease, so what is the new advance that you think we need to discuss?
So at today's meeting, we concentrated on what are the new treatments for moderate to severe ulcerative colitis, and also what are new recommendations for mild to moderate ulcerative colitis that have been published in last month's gastroenterology from the American Gastroenterology Association. And one of the exciting new medications is tofacitinib, which is a oral anti-JAK1, 3, and to a lesser extent JAK2 inhibitors, which can block some of the inflammatory cytokines, including those that may be more specific for ulcerative colitis. And so this now gives patients a new option in addition to the biologics of anti-TNF alpha therapy, the anti-integrin therapy, vedolizumab, and also thiopurines for moderate to severe ulcerative colitis.
This is excellent. So how much the landscape has changed during the last 5 to 10 years?
So fortunately, we're at a much better place for our patients with more severe ulcerative colitis than we used to be. Beginning with infliximab being released in 1998, and then after initial use in Crohn's disease becoming approved for ulcerative colitis, we had another option besides corticosteroids and thiopurines to control ulcerative colitis. And we're still using infliximab as a priority drug, along with golimumab and adalimumab for ulcerative colitis using the anti-TNF alpha therapy. But then in 2014 was released vedolizumab, which in a way is a designer drug for inflammatory bowel disease because it blocks the integrins on white blood cells that allow the white blood cells to traffic into the inflamed gut. So the nice thing about vedolizumab is that it is targeted specifically to the gut immune system, and it has very low risk of infections because of not suppressing the immune system outside the gut. So that has really been a nice new choice. And then most recently, in May of last year, was released tofacitinib. It is not a biologic. It is a chemical compound that is a JAK inhibitor, as I mentioned. It seems to have a similar type of efficacy as the other medications, but where it may have a special niche is that it was found, unlike vedolizumab or unlike the other anti-TNF alpha medications, to have just as much effect after patients are exposed to anti-TNF alpha therapy as it would in patients that are naive to anti-TNF alpha therapy. So if patients have tried anti-TNF alpha therapy and failed it, then going to a second anti-TNF alpha agent has found not to be as effective, and going to vedolizumab has found not to be as effective as in the naive patients. In the case of tofacitinib, it showed equal efficacy whether or not patients had anti-TNF-alpha exposure. And I think for that reason, it may have a niche in those patients that have had exposure to anti-TNF-alpha therapy and failed it.
So those news sound very exciting. Do you really believe that there are difficult to treat population nowadays in regards to inflammatory bowel disease, or with all of these compounds, it's easier and this population does not exist or has declined?
Well, unfortunately, especially for Crohn's disease, we don't have good treatments for the 30% or so patients that develop stricturing Crohn's disease. So there's no medication we know now that prevents it. There was an exciting study in children under the age of 18 with a median age of about 12 and a half, published from the RISK Consortium, which looked at new onset Crohn's disease. They found that those children that were treated early with anti-TNF-alpha medication were spared of penetrating, fistulizing complications that also occur in about 30% of patients with Crohn's disease. However, it did not seem to have an effect on the stricturing complications in those children. So now it does seem that early treatment of with the anti-TNF-alpha therapy in patients with early onset, more severe, deep ulcers, extensive Crohn's disease, especially those with any early evidence of fistulizing complications, may prevent hospitalizations and may prevent new fistulas from forming, or fistulas in the first place from forming. But as far as the stricturing, we're not sure how to prevent that kind of complication. And that is still a major reason that at least 50% of people with Crohn's disease will eventually need surgical resection of part of their bowel. So there definitely is work to be done there.